to chair the session, and I welcome Mohamed Bedaiwy to start our session number 3.
Bonjour.
Hello, good morning. Can you hear me?
Who is starting?
Is it?
Mohamed is the first one.
Okay. Sorry for this misunderstanding. Okay, I'm Professor Ben Khalifa from Paris. Welcome to all of you, and I would like to thank the organizer for this kind of invitation and also the organization of this very interesting session for our colleagues interested to on endometriosis and reproductive pathology. The speakers is Dr. Mohamed Bedaiwy from Canada, and he will talk to us about the endometrioma in the infertile patient and a tyrant approach. More than welcome, Dr. Mohamed, and the floor is yours.
Good morning, good early morning from Vancouver, and thank you very much for the kind invitation. Here are my disclosures. I'll try to as practical as I can, and also
Dr. Mohamed, can you open your microphone?
It is open, I think.
Your microphone is mute.
All right. No, it's not. Actually, my microphone is working. Can you hear me?
Yeah.
Hello, can you hear me? Hello?
Yes, yes, yes.
All right. Yeah, can you see me? Can you see my slides? All right. Well, without any further ado, again, thank you for the committee for inviting me. So my focus on my talk will be on
the microphone of Dr. Mohamed.
I think I am muted from your side now.
It's open, it's open.
Yeah, can you hear me?
Yes, we hear you.
Okay, so basically endometrioma is one of the phenotypes of endometriosis, and it can be also associated with other phenotypes. So keep that in mind. So my objectives will be, what are the treatment options and why treatment should be individualized in patients with endometrioma? And if we are to remove endometrioma, when and how? And what are the consequences? And I wouldn't spend a lot of time on the consequences because you hear them from the previous speaker, and touching briefly on the impact of endometrioma surgery on IVF. So it is as common as up to 44% of patients with endometriosis, and bilaterality in this disease could be up to 28%. So the first question I would like to pose to the audience, how thick is endometriotic tissue within the endometrioma? Actually, it's not very thick. The endometriotic tissue, when you open the cyst, it's approximately 0.6 millimeter in terms of its mean. With that, when we are talking about treatment options, we are talking about one of four: doing nothing, or doing a proper surgery, or moving to IVF, or doing surgery followed by IVF, or IVF followed by surgery according to the clinical scenario. So basically there is no one size fit all here, and one size does not fit all of our patients. That's why it continues to be controversial as to what to do with endometrioma when we start to individualize treatment options. And that's coming from the fact that we do not have RCTs comparing fertility outcomes after surgery for endometrioma in comparison with expectant management, nor studies exploring the indications for surgery depending on the size of the cyst. So for instance, if you look into this small video, that you see a very small endometrioma with an MSERM of ovarian follicles, and the ovary is mobile, hence the endometriosis fertility index would be normal. So this patient can even try to get pregnant on her own if everything else is normal. Similarly, even with bilateral small endometrioma that are accessible with confirmed tubal patency and mobility, trying to get pregnant in their own, if all factors are normal, is also possible for a short duration of time. On the other side, if you look into this patient, you could see an endometrioma on top of the ovary here with, that is adherent and very expected low endometriosis fertility index, so they cannot go ahead and try to get pregnant in their own. And also, even if you try to do IVF in this patient, you have to go through a lot of soft tissue, and the retrieval is not going to be easy, given how fixed the endometrioma to the top of the uterus is. Similarly, with two ovaries here, you have two casing endometriomas, and you can see here that they are on top of the uterus as well. So accessibility is a big issue. In addition, endometrioma, as I said in the beginning, does not come by itself. It has companions. One of those companions is adenomyosis. So there is a uterine factor here with a big fixed endometrioma and posterior cul-de-sac next to the uterus on the other side. So again, accessibility and ability for spontaneous conception is jeopardized here. So this is a patient with two huge endometriomas where the two ovaries eroded in each other. It's not only casing, and they are fixed in the pelvis. So again, there's an accessibility factor when you go to IVF. Another variant, you have a huge endometrioma going all the way to the umbilicus, and you can't really do that much in those patients without surgically correcting that endometrioma. And even with huge endometrioma, you can still do ovarian cystectomy and preserve ovarian tissue. So who is a good candidate for surgery when it comes to endometrioma surgery? Women with intact ovarian reserve, and preferably with an AMH of 3.5 nanograms per ml, and I will tell you shortly why. If there's a rapid growth, there's severe disease or debilitating pain, and there will be an accessibility issue if they are huge, and obviously if there is a suspicion of cancer, and preferably with unilateral disease. When to treat, people try to come up with different algorithms like this one you see in front of you, based on the size, the growth rate, the pain, and the duration of infertility, and the ultrasound features, and the history of positive, family history positive for cancer and recurrence of endometrioma, and even age. So people recommend surgery if the score is more than 3 according to this algorithm. So how do we treat patients with endometriomas? There are many options, but the two most practical ones are laparoscopic ovarian cystectomy or ablation of the cyst wall, or a combination of the two. So according to that guidance that came earlier before the 2022 guidelines from the ISHRAE, cystectomy and ablation and the combined techniques are the three most commonly used ones. So let's go through them. So when it comes to laparoscopic cystectomy, there is a significant improvement in the pain symptoms. Spontaneous pregnancy rates increase, and there is reduced recurrence compared with ablation. And histologic diagnosis in a large series showed that the risk of occult malignancy is less than 1%. However, as the previous speaker said, there is a significant decline in the ovarian reserve secondary to the surgery, and that significant decline has been shown over and over again in many studies, this is one that tells a systematic review that tells us that there is an up to 30% fall of the anti-Mullerian hormone with unilateral cystectomy and up to 44% fall after bilateral ovarian cystectomy. And there is a larger risk of premature ovarian failure if the endometriomas are bilateral, that could be up to 2.4%. So one question would come here, is the postoperative decline in AMH permanent? According to data, it does not seem to be that case. This is data from Cleveland Clinic, from Dr. Falcone, he's one of the speakers. If you compare the anti-Mullerian hormone postoperatively to the baseline in patients with endometrioma, there was a significant decline 1 month after surgery. But if you remeasure it again after 6 months, that decline improves actually, and it's no longer significant compared to the baseline. And there are many subsequent studies listed here that showed that the AMH, there would be some sort of recovery after surgery, after proper surgery, quote unquote, but it's not a complete recovery, obviously. How would you predict that your patient would have a diminished ovarian reserve after surgery? AMH is a good predictor, and you can use the different cutoff levels here. For patients with unilateral endometrioma, 2.1 nanogram per ml preoperatively seems to be a good cutoff limit that you can use to counsel your patients about their increased risk of diminished ovarian reserve, and 3 nanograms after 3 months of surgery for bilateral disease, and 3.5 to predict diminished ovarian reserve 6 months after surgery. How do you minimize the damage to the ovary at the time of ovarian cystectomy, which I think would be the focus of the rest of the time left for me here. So experience. There are so many studies that showed that inexperienced surgeons, when they tackle endometriomas, their patients are more likely to have diminished ovarian reserve and poor response. So the technique that is recommended and that we use, as you can see in some of these video clips, is based on incision, aspiration of the cyst contents. So try not to do the cystectomy or take the cyst intact. It will rupture at a certain point of time. So better to rupture under control from the beginning, and then you move on. We almost always inject vasopressin between the cortex and the cyst wall, and we try to develop the plane between the cortex and the cyst wall. Staying in the correct plane removes less normal tissue and causes less bleeding, necessitating cautery, which is a detriment to ovarian reserve. And the separation between the cyst wall and the ovarian cortex is done in a stripping technique. We irrigate at the end of the surgery, and most of the time we use a coagulation current sparingly, which rarely used if you use one of these options, vasopressin or hemostatic agents, or even suturing, and try to avoid bipolar cautery. There are many studies that indicated that the use of dilute vasopressin, we use 10 units and 200, so it's very dilute, is associated with less reduction of the ovarian reserve post-operatively. And I have a small video clip here to show you how to inject vasopressin in patients with endometrioma. You go right below the cyst wall, and using the aspiration needle, you just go ahead and blow it up. It leads to hydrodissection, which will subsequently lead to easy stripping of the endometrioma from the ovarian cortex, as you can see here, with very little bleeding noticed. So most of the time we do not need to use cautery. One of the options we use for huge endometrioma, specifically when the bed is quite open, is suturing. We're using burst string from within to avoid having sutures on the outside surface of the ovary to diminish bleeding and decrease the need for cautery. Flow seal, if it's available in your institution, is a collagen granule, and thrombin is also helpful to stop bleeding without resorting to using any coagulation. For the majority of our cases, given the high likelihood of associated deep infiltrating endometriosis, we do excision of endometriosis at the time of ovarian cystectomy. So basically, we do temporary ovarian suspension, as you can see here, where both ovaries will be suspended temporarily for 7 to 10 days at the end of the surgery to avoid sticking to the pelvic side wall and decrease bleeding and prevent the tubes from being blocked. You see here the lateral pelvic side wall dissected, beautiful fimbria on both sides. This patient would have a very decent endometriosis fertility index, and there is a meta-analysis of 2 RCTs and 6 non-randomized trials that showed that ovarian suspension decreases the risk of adhesions after. So when we resect endometrioma, according to this review, the chance of spontaneous pregnancy after laparoscopic excision ranged from 30 to 67%, depending on other factors. And that is another meta-analysis based on 2 RCTs that showed that cystectomy and stripping is better than ablation. When it comes to IVF, you can simplify it in 3 points. So the effect of untreated endometrioma compared to women with no endometriosis, they have a similar live birth rate, similar miscarriage rate, decrease in the mean oocyte rate, and there is increased IVF cycle cancellation up to 3 times in patients when endometrioma were not treated. When there was a surgical treatment of endometrioma compared to untreated endometrioma on the other side, compared to untreated endometriomas, you have a similar live birth rate, cumulative pregnancy rate, and miscarriages, but with decreased antral follicle count and increased need for gonadotrophins in patients who underwent surgical treatment. When you compare surgically treated versus normal contralateral ovary, you always get less oocytes from the treated ovary. So the ASHRI guideline, when it comes to that part, as it pertains to spontaneous conception, it recommends that clinician may consider operative laparoscopy for the treatment of endometrioma-associated infertility, as it may increase their chance of natural conception, although data from comparative study does not exist. Take that with a grain of salt, because there are so many other confounders, including the patient age, the duration of infertility, the ovulatory status, the ovarian reserve factors, the male and tubal status, in addition to the endometriosis-associated factor like the stage of the disease, the presence of OMAs on the other side, and DIE, and most importantly, endometriosis fertility index, particularly if your patient is not going to pursue IVF. Concurrent pathology is quite important, and the 3 common concurrent pathologies we see in patients with endometriosis in general are adenomyosis and fibroids and polyps. All of them pose a uterine factor to be taken into consideration when you try to make treatment decisions for your patients. So in summary, the benefit of endometrioma excision for pain management is consensual. Nobody disagrees with that. But surgical excision for the sole purpose of improving reproductive outcomes continue to be controversial, particularly in patients with intact ovarian reserve. AMH should be included in the evaluation of reproductive age women with endometriosis, and the decline in the ovarian reserve after ovarian surgery is multifactorial. It's not dependent on the surgery alone. It's inevitable regardless of the technique, but the experience do make a difference. And it could be temporary and can be at least partially recovered after the surgery. When you do endometrioma surgery, typically this is not offered to every single patient with endometrioma-associated infertility, and you have to consider fertility preservation options, particularly in patients at risk of diminished ovarian reserve if surgery is inevitable. Proper selection of cases, proper timing, and proper technique and experience do matter when it comes to the outcome. We have to stop and minimize the bipolar electrocoagulation because we have other alternatives, as I explained earlier, and thank you very much for your attention.
Okay, thank you very much, Bedaiwy, for this nice and clear presentation. Now the presentation is open for question. Any question for Dr. Bedaiwy?
Yes.
Or yes, please introduce yourself.
Please. Yes, please. Dr. Abu Bakr Nashar from Egypt. My regards to Dr. Mohamed. Ramadan Kareem, Dr. Mohamed. Thanks for this nice presentation. You mentioned the AMH can be increased after surgery. What is the explanation for this?
Well, the short answer is that there's no clear explanation, but there is a recovery process and a healing process that happens in the ovary, and specifically the blood supply. When you do extensive dissection at the time
there is a formation of a new
well, I'm just telling you that the recovery of the ovary itself in terms of its vascularity is a potential factor, and also the fact that the measurements are done shortly after surgery is probably not recommended if you want to know exactly where. Not routinely recommended, I would say shortly after. If you want to know your actual AMH after the surgery, you may need to wait for some time, according to the data that we have, anywhere between 3 and 6 months after.
What is the recommended time for evaluation of AMH after surgery?
Well, as probably, I'm not sure if Dr. Falcone is in the audience, he usually say that don't measure it after surgery, but the most important factor is your baseline AMH, and that's what you're going to use to make a decision whether to proceed with the surgery or not. I would measure it if the patient is going for an IVF treatment or she is undergoing controlled ovarian stimulation. I would say 3 months or more after the surgery. Yeah.
Thanks a lot, Dr. Mohamed. Very nice presentation and updated one.
Thank you.
I have one question to you, Dr. Mohamed. Do you think after the surgery, we are reducing the inflammation profile, probably by also reducing the impact of cytokines and interleukins level in the ovary to improve AMH?
That's definitely one of the arguments that the pro-surgery campaign proposed towards endometrioma, but it seems that there is an effect in that direction. But again, that is to be balanced against other factors, as I said earlier, because at the end of the day, there are patients that you must operate on, because otherwise they would never get pregnant either on their own or even with IVF if the ovary is 15 centimeters or so. So the whole idea here, yes, there is some